Hello, everyone. Welcome to the Dr. Sophia ObGyn Podcast. I'm an ObGyn practicing for over 15 years in my native New York City. And I love to help women learn about their bodies, empower them, and embrace themselves. On this podcast, we talk openly and with heart about all things affecting women, from pregnancy, menopause, periods, sexual health, fertility, and so much more. Disclaimer: this is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Hello, everyone, and welcome to the Dr. Sophia ObGyn Podcast. Today, we're going to kind of dive into what a day in the life of Dr. Sophia is. And of course, this all started from a conversation with my good friend and co-host, Touseef Mirza.
Hi, everybody.
So, Touseef and I, we talk all the time. And often what we talk about, she asks me, so how was your day? Or what was happening in the hospital today? And so I was telling her how my day was a little bit frustrating. And she was like, really? Well, what happened? You're usually so happy-go-lucky. And though I'm usually very, very happy when it comes to seeing patients. And I'm taking accountability that maybe I'm, approaching my cycle. I'm a little bit moody.
Yes, we didn't realize that yesterday when we were talking.
When we were talking yesterday.
And when it was in the whole conversation and she was in it. And today we've come to realize that there's a reason for that.
Yes, because I woke up with cramps and I was like, again, it gets me again.
See, it creeps even in the body of an ObGyn because you are a woman after all.
But anyway, today's podcast is not about my period.
We can go there if we want to. Also, for me, what's interesting is, I'm not a healthcare professional and I go see doctors, I go see different healthcare professionals. And so it's also to understand, sometimes when we go as patients, sometimes we have all of these expectations of what a doctor can do for us. And actually, they can do a lot, but it's not like they're, absolute gods. And I think that's part of the problem of how doctors have been portrayed.
Yeah. So I work as a generalist ObGyn. I deliver babies. I, cover the labor floor. And as part of that, I also work with other colleagues. And sometimes that means that I also have to cover or see their patients. Like, for example, if a doctor has a patient that's coming into the labor floor, but that their particular doctor is not present, I would see that patient. And when I see the patient, I would then report back my findings. And then that kind of will determine if whether or not that doctor needs to come in. So what would happen is I would evaluate the patient and then kind of give them recommendations or something like that. But ultimately, it's not my patient, it's their patient. And so yesterday, this wasn't actually the patient who was kind of a little frustrating for me, but more so the situation in something that the way I would have actually dealt with the case versus totally complete normal patient care, but the way that doctor chose to deal with the case. So I have a patient who comes in and she's complaining of something called decreased fetal movement. So
she's pregnant.
She's at term being anywhere between 37 and 42 weeks. And she's actually more like maybe around 38 weeks. And her pregnancy happens to be complicated by something called gestational diabetes. And so she's coming in with a complaint of decreased fetal movement. Now, when a woman comes in with decreased fetal movement, we are very concerned, especially at term, because here we have a baby who's fully able to survive outside of the womb.
So she's 7 months pregnant at this point.
No, she's 9 months pregnant.
9 months pregnant? Oh, okay. I'm sorry. It's early in the morning. I'm not fully awake. Okay. I work in months. I find it's easier when we talk about pregnancy.
Oh,
but yes.
the problem is that OBGYNs, we think in weeks. That's so true.
The rest of the population will
It's
take
not.
months.
That's so true. Okay,
We're always
she's
like,
9 months.
okay,
She's
what
9
is-
months.
what does
She's
that
term.
mean?
She's
I
9
mean,
months.
okay.
She's 9 months pregnant.
Okay.
But that's the thing. You see, for us, we're like, yeah, but you're really pregnant for 10 months.
Okay.
When you're at the end, like that due date, you're actually 10 months pregnant. So that's why it's harder for me to function in that way. But it's okay. I can do it because
You're doing great.
I want my audience to understand. So
Including myself.
you.
Yes,
Yeah, for
thank
sure.
you.
So if we function in months, anyway, I'm going to call her 9 months pregnant because that's what everybody understands as once you're 9 months, you're ready to go. So at 9 months, we want this baby is good in and out. Let's just say it that way. But when a woman comes in for decreased fetal movement, it could be a number of reasons why she's having decreased fetal movement or why she senses that she's having what we call decreased fetal movement.
So this is not something that she was diagnosed as. She just started to feel in her belly that all of a sudden the movement that she was feeling before, she's not feeling as much now.
Right.
Okay.
It's a change.
It's a change,
a shift, and sometimes what really is happening is that a mom is like, busy going about her day and what have you, and may not feel the movements that the baby's actually having because she herself is moving and busy and what have you. And so I usually tell women when they notice that they don't feel the baby moving to stop for a second and just maybe drink something cold, sweet, and rest. If they can, lay to their left side so that they can improve the blood flow back to the placenta.
So I haven't had a baby. So does that mean that when you're around like 7 to 9 months that you really, you're basically almost feeling the baby all the time? And if you don't, then you should do something about it?
So babies move in their own patterns.
Okay.
And yes, are they moving all the time? Yes, to some extent, I would say they are. However, they have sleep cycles, they can rest too. So I like to tell women to understand and pay attention to what their baby's pattern is. And really, it's when they see or feel a change in how their baby usually moves. A lot of babies tend to be a lot more active at night, or at least mothers perceive the activity more at nighttime, for example, and early mornings. I don't know why, but this is, it seems like what happens oftentimes. And whereas during the daytime, though they feel the baby moving, but maybe it's not the same intensity or, punchy. And again, I think it's just because women are busy. They are also going about their day, going to work, doing things. And so it might be part of the reason why they don't feel the baby as much. Nonetheless, if they take a moment to rest, like I said, do something like, sugar, food, those things like to kind of trigger the baby a little bit. And then that's it. Baby gets moving again like normal. And if that happens, great. Then you can pretty much feel rest assured that everything is just fine. However, in a situation where you feel like it's been a couple of hours, you notice that the baby hasn't been moving. First of all, certainly, once you think about it, don't wait hours. That's one of my first things that I like to tell patients. It's different if you notice now it's been a couple of hours. That's different than if you've noticed it and then wait more time. Not necessary.
Okay.
In the conditions of a woman who has this complaint, we would typically do an ultrasound and we would put them on something called an NST or non-stress test or monitoring. They'll often hear people say, oh, I have to be monitored. And that monitoring is fetal monitoring, where we put some straps on your belly and it listens to the baby's heartbeat. And so the combination of the NST, non-stress test or monitoring, along with an ultrasound are the two things that can give us a lot of information and reassurance.
Is this usually customary tests that you do on a regular basis during pregnancy?
So it depends on, what potential other issues may be happening with the pregnancy in terms of how often one would get, let's say, a sonogram or monitoring under certain conditions. Then yes, we do exactly that. looking at what we call fetal well-being. But for sure, we would do it in a case of what we call decreased fetal movement. So yesterday, patient has the complaint of decreased fetal movement. She comes in, she gets her ultrasound, she gets her monitoring. Everything looks great.
Okay.
And so we're reassured, but that I have a healthy mommy and a healthy baby today, doctor, and knowing the other conditions. So here's where perhaps I differed from my colleague. Ultimately, the patient wasn't delivered yesterday. She'll be delivered tomorrow.
Okay.
So it's just 2 days.
Okay.
And the patient herself was very content with the fact that by the time she left the labor floor, she was herself feeling the baby moving like normal. We'd given her a lot of fluids and
She was feeling better about it.
she was already feeling much better about it. She's like, oh, the baby's moving totally like it normally does now.
Okay.
And everything. And here's the thing, as an OBGYN, we are always managing 2 patients at the same time. Like always.
Which is?
The mother and the fetus. All the time.
You're thinking about the health of the mother and also the health of the baby.
Yes.
And figuring out what's the right balance.
Correct.
Yeah.
And I think, so this is where for me, because I always have that in the back of my mind, I'm taking care of 2 people. And one of them can't talk to me.
Yes, it's deep inside. No sign language, no nothing.
You know, yes, of course. I'm so thankful for technology. I have the monitoring, I have the ultrasound, I have ways of which to see how is this baby doing inside its little home, the womb.
Mm-hmm.
It's not giving me facial expressions. I don't have all of that to go with. And so, though I'm not an alarmist by any means, I guess I could consider myself a little bit more on the side of caution or conservative, perhaps. Mm-hmm. There was a part of me yesterday that felt uncomfortable letting that woman go home.
Even though she was coming back the next day.
Even though she was coming back in 2 days.
And that's because she has on top of that, has gestational
So on top
diabetes.
of that, yes. So on top of her complaint of decreased fetal movement, she also has gestational diabetes.
Okay. And so what is exactly gestational diabetes versus like diabetes by itself?
So the thing is that diabetes, so if someone is pregnant but has diabetes before they become pregnant, they're just a diabetic. But someone who has never had diabetes before and then develops diabetes in the pregnancy is considered gestational diabetes. And one key difference is that someone who had diabetes before pregnancy has diabetes throughout pregnancy and is still a diabetic after pregnancy. So after they deliver, they're still a diabetic. Whereas someone who is a gestational diabetic has diabetes that's diagnosed only in the pregnancy, and it resolves with delivery.
Which means after you deliver the baby, you don't have the diabetes aspect in your body anymore.
Right. I mean, it's a little bit more nuanced than that.
Yeah.
I mean, in the sense that we no longer consider you a diabetic. Mm-hmm. Let's just put it that way.
Okay.
And then we test you for diabetes because you're just at an increased risk of developing actual diabetes after you've had gestational diabetes. But the cause of gestational diabetes is the pregnancy itself. So it's the way that your body handles some of the hormones that are released during pregnancy that then can increase your insulin resistance. And so because the resistance for insulin is higher during pregnancy is what causes you to have the gestational diabetes.
So basically, you're healthy, you don't have diabetes, you get pregnant, you have a chance of potentially have gestational diabetes that is basically just caused by the state of your placenta.
Your hormones.
And some women go through that and some women don't.
Our body is meant to function in harmony. And so when we get pregnant and we release all of these extra hormones, and especially one specifically that comes from the placenta, your pancreas is like, okay, this is what we're doing. And it kind of tries to keep up with what's going on with this brand new organ that developed when you were pregnant called the placenta. And they're kind of playing this little dance. But for some people, the pancreas is just not able to keep up with how the demands of what's going on with the pregnancy in terms of glucose load and hormones and how
fascinating.
It's fascinating. It actually is very fascinating. So anyway, the problem with gestational diabetes.
Yes. I love talking about this stuff. I love the science behind it. This is literally how we talk together. Like, okay, but what does this mean? Okay, well, what does that mean? I said, let's do a podcast about this.
This is always how it comes out. So when we have gestational diabetes, you are increasing the sugar that is in your bloodstream and sugar that's present around the baby. And unfortunately, diabetes is a risk factor for a lot of things. One of them being preeclampsia, for example.
Oh, okay.
Okay. Also, hyperglycemia or hypoglycemia, meaning that once your baby is born, that the baby, because it was used to this big sugar environment, and then once it's born, that sugar drops pretty drastically. And when you have hypoglycemia, that is also very dangerous. You know, it can cause the baby to have jitters and, you know, it has its own consequences. It can also increase like all-cause mortality, just like in terms of for the baby, you know, like increases your risk of even having stillbirth. So it's just, I'm just like, I don't know.
There's all these things to consider. When does gestational diabetes in the pregnancy can start to like show up? Like in terms
we
of the
usually
diagnosis?
test women somewhere between 24 and 28 weeks.
Okay.
So like around 6 months.
Okay.
Is when we screen them to see if they developed diabetes in the pregnancy. And we do that by giving them what we call a glucose load. So we give them a very sweet, sugary drink, and then we wait an hour, and then we test their sugar in their blood. And for most women, they're able to handle it.
Okay.
Right? That's your body's working and functioning normally. And so
To process
right, that sugar load. And so that's around 24 to 28 weeks, ideally.
Okay.
And then in a woman who may have, let's say, increased risk factors for developing diabetes, perhaps she had a condition before pregnancy called PCOS, which already increases what we call insulin resistance. Perhaps she was already pre-diabetic. That would increase her chances of being diabetic in pregnancy. Perhaps she's overweight or is obese. That increases her chances of having diabetes in pregnancy. And so with all those things, we would test them even earlier. And really, as soon as we know that they're pregnant, typically in those first couple of weeks or first labs that we do, we check to see if they have diabetes even at that time.
Okay.
So way before the 24-week mark.
So then you have this woman and now she's feeling fine and she's like, okay, I can go back home now. But now you have this feeling in your gut where you're trying to like say, all right,
that gut feeling. And it's so, you know, but she's not my patient. And we've done standard of care. It's not like we've done anything. We haven't deviated from it by any means, you know, and it's just the concept also of when you are personally taking care of a patient, when it's your patient, how you either develop the relationship and how you can perhaps have more, whether it's tolerance or how else to call it, but like a connection with the patient. By all means, I'm sure her doctor had all those things, right? The stuff that I was missing in that moment was the connection. So all I had to go with was, look, who's in front of me right now? And I'm like, oh my God, but she's a gestational diabetic and she had decreased fetal movement. And for me, it was like the second time she'd made this complaint in maybe 72 hours or something like that. And so for me, I was like, what's going to happen in 3 days? It's already been 3 days since she's here again because of decreased fetal movement. I don't know. Why is the baby doing that? I don't know why the baby's doing that. Why is the baby not moving?
So then you're just like, all right, if that woman was your patient, then you might have said, let's just keep you in the hospital.
She was a woman who was going to be induced.
Yeah.
And so it was going to be probably, if it were my personal patient, I probably would have been like, okay, today's the day.
Let's just do it.
Yeah.
Let's just do it.
Yeah.
And it's not to say that the other healthcare provider was wrong.
No.
It's just that different OBGYNs or different practitioners have their own way of assessing. So I think this is an important point for us in the lay public to understand also that it's not always an exact science.
That it's not just that it's not an exact science, but there's room, right? There's room in the care of what can be expected or what can happen.
Right.
You know what I'm saying? And so it was just a conflict for me. The patient was totally fine. My report back to that doctor is, yes, everything is as it should be. And so they're making that decision based on what I'm saying.
Right.
And that's the truth.
They're the lead. Yeah, right.
Right?
Yeah. And that person said, yes, she's good. You can
send her home.
Send her home.
Right. I felt like there was another way of handling the situation. And at the end of the day, it wasn't my call to make. And I got frustrated by that.
I mean, I think from my perspective or from a layperson perspective, I think this is not something that we think about when we interact with healthcare professionals, that they also have yes, there's the science, but then there's also that room that you talked about, right? Of how to take care of patients, that you have more flexibility of making the call, and that's something that you have to deal with and sort of consolidate within yourself.
Yeah.
It's not black and white.
It's not black and white. That is so true. It's not, there's definitely a gray zone, there's a gray zone in how we can care for our patients. And moreover, there's differences between one provider and the next, and that's totally okay. But the conflict within me in that moment is what was frustrating.
And then you have to let go.
And then I have to let it go. Yeah, for sure. I have to let it go.
So that's part of dealing with work. Any topic that we're involved in, there's all these different variables, right? It's so rare that it's on the straight and narrow on one line. And you have to figure out how to navigate that.
For sure, medicine is not on one line. There's no question about that. And I feel like if there's anything that has a lot of zigzags, it's OBGYN. So, that was one patient. I'm happy to bring these type of stories because I think that it's important for our audience to see what it's like both on the patient side as well as from a provider standpoint. And so I just hope you are all enjoying listening to us here on the Dr. Sophia ObGyn Podcast and the different perspectives that we share.
And also just to view different people and their lived experiences and what other women go through. Because for us, it's not just about giving medical information, but it's really about exploring what are women actually going through as they're going through pregnancy or going through whatever it is. But it's to really look at the evolution of that and how people are feeling and what they're going through.
And how I'm feeling and what I'm going through.
Your lived experience as well. Yes.
Well, I mean, at least what my colleagues and I, some of the things that happened to us. And I do think that it's important to bring that little tidbit or that part of it.
I mean, let's just be clear. If for any reason you thought that something was really wrong, even if it wasn't your patient, you would have called that out.
100%, 100%.
Right. So let's just be clear about that.
Oh, yeah. Let's be very clear. I mean, like I said, the standard of care was definitely met with this patient. And she is excited. She's expecting her baby. She gets to go home and plan, right? As opposed to me being like, well, could you just stay? No, and then have to like rearrange her whole day. She's got her and her provider made a decision, and that was fine. That was totally fine. And yes, had she been in a danger zone for whatever reason, I would have had a conversation with the provider in terms of why I feel like they're in danger. And then, of course, that dialogue would have happened. But definitely, that's not what was going on. And I'm happy that we talked about this. It's actually making me feel so much lighter.
This is your therapy right now. This is, how you always say at the end, embrace your body, embrace yourself. Well, I will say that to you today. Embrace your body, Dr. Sophia, and embrace yourself.
Okay. I will take it.
Take it for the whole day. Just love on yourself today.
Thank you.
You're
Thank you,
welcome.
Touseef. I appreciate you. To our listeners, thank you so much for listening to the Dr. Sophia ObGyn Podcast. We really appreciate you. And as always, embrace your body, embrace yourself. Thanks for listening. Bye.
Bye.
This is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Until next time, embrace your body, embrace yourself.